Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings. I am delighted to welcome you to the multimedia summary for the journal's October 2017 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is an original article that examined perspectives of clinicians regarding bedside decision process in the timing of intubation and sepsis-associated acute respiratory failure. This article is authored by Dr. Philippe Bauer and colleagues from the Division of Pulmonary and Critical Care Medicine, the Center for the Science of Healthcare Delivery, and the Department of Anesthesia Clinical Research at Mayo Clinic in Rochester, Minnesota, and Bridgeport Hospital in Bridgeport, Connecticut. In this mixed methods study, the authors first conducted a qualitative analysis of semi-structured interviews with critical care clinicians in a convenient sample of patients to determine what triggered the decision to intubate or not. The study took place in 3 intensive care units at a single institution with 24-hour in-house faculty staff coverage. The authors point out that clinicians commonly limit intubation to the most critical patients to prevent complications associated with mechanical ventilation. They found that the practice of intubation varied according to 3 domains. First, patient factors such as their level of illness and comorbidities. Second, clinician factors such as training, experience, and practice styles. And third, system factors such as workload, policies, communication, and team dynamics. In different contexts, intubation was considered early, elective, just-in-time, urgent, or late rescue. And in this regard, the initial assessment, initial decision, and reassessment all mattered. Variation in the timing of intubation largely reflected 2 key issues. First, clear evidence that links the efficacy and safety of intubation with its timing in this population. And second, the lack of explicit consideration of the patient's course. The authors thus conclude that in the absence of firm evidence pertaining to such efficacy and safety, explicit and reasoned decision-making may be a superior approach to improve care. The authors point out that a standardized approach may be premature and may not be in accord with perspective or practice of frontline clinicians. Finally, the authors underscore that a greater cognizance of the variations that exist in the timing of intubation and the underlying factors should promote more clinical attentiveness to the course, in particular, the progression of acute respiratory failure. Our first highlight article is a concise review for clinicians that examine the common tendency for weight gain in women in midlife with a propensity for central fat distribution with such weight gain. This article is authored by Dr. Etka Kapoor and colleagues from the Women's Health Clinic, the Division of General Internal Medicine, and the Division of Endocrinology, Diabetes, Metabolism, and Nutrition at Mayo Clinic in Rochester, Minnesota. On average, women gain about 1.5 pounds, 0.7 kilograms per year during their 5th and 6th decades of life, independent of initial body size, race, or ethnicity. In the United States, nearly 2/3 of women aged 40 to 59 years and about 3/4 of women 60 years and older are overweight. Increased body fat is associated with adverse metabolic consequences and an increased risk of cardiovascular disease being the leading cause of death in postmenopausal women. The current literature largely supports the view that weight gain in midlife women is primarily the result of aging and lifestyle changes, and that menopause per se does not result in significant weight gain after adjustment for aging. Aging is associated with decreased physical activity, which in turn may decrease lean body mass and resting metabolic rate. The authors reviewed management of such weight gain, recommending, where possible, a team-based approach. Management strategies include dietary modification, physical activity, and behavioral support, and when appropriate, menopausal hormone therapy, weight loss medications, and bariatric and endoscopic bariatric therapies. Also discussed is the relatively common occurrence of significant weight regain after initial weight loss. The authors conclude that medical practitioners should actively screen midlife women to determine if they are overweight and then offer appropriate education, treatment, and support. Such management should address also symptoms that occur in midlife women, such as vasomotor symptoms, mood disorders, and sleep disturbances, all of which may interfere with adoption of healthy lifestyle measures. This article provides up to 1 hour of CME credit to readers who complete the tests and appropriate documentation. The second article is an original article that evaluates association between mortality and limitations in mobility and cognition in older adults. It is authored by Ms. Emily Frith and colleagues from multiple departments and centers, including physical activity, epidemiology, geriatrics, neurology, and memory, all located at the University of Mississippi. The premise of this study resides in the linkage of certain aspects of cognition to physical activity, and the linkage of impaired physical capacity with increased morbidity and mortality. Using data from 1999 to 2002 National Health and Nutrition Examination Survey, the authors identified 1,852 adults aged 60 to 85 years with and without mobility or cognitive limitations. Hazard ratios for mortality risk were calculated for 4 groups: those with no limitations, those with mobility limitations only, those with cognitive limitations only, and those with both cognitive and mobility limitations. The main finding of this study was that both limitations were independently associated with an increased mortality risk, with the highest risk being observed in older adults with both limitations. In the adjusted model that controlled for age, sex, race, and other relevant variables, the risk was attenuated, particularly in those with both limitations, but still significantly increased. The authors conclude that cognitive impairment and mobility limitations associate with mortality risk, the magnitude of the risk being ultimately influenced by demographic and behavioral characteristics. The third highlight is an original article examining the clinical presentation, hemodynamics, management, and outcomes of patients presenting with saddle pulmonary embolism. It is authored by Dr. Bhaskar Al-Kilini and colleagues from the Division of Pulmonary Critical Care Medicine and the Department of Anesthesia and Critical Care Medicine at Mayo Clinic, Rochester, Minnesota. Acute pulmonary embolism is a potentially life-threatening disease and a leading cause of cardiovascular morbidity and mortality. In this study, the authors identified a total of 187 consecutive patients with saddle pulmonary embolism. Saddle pulmonary embolism is a radiologic definition in which the thrombus straddles the bifurcation of the pulmonary artery trunk, often with extension into the right and left main pulmonary arteries. It is found in approximately 2 to 5% of all patients with pulmonary embolism. Based on initial clinical presentation, study participants were stratified into one of 3 hemodynamic categories: massive, submassive, and low-risk pulmonary embolism. Although patients with saddle pulmonary embolism were more likely to present with massive or submassive pulmonary embolism, they did not carry a higher risk of in-hospital mortality compared with mortality in the severity-adjusted non-saddle pulmonary embolism cohort. Mortality was relatively low in both groups. Rates of vasopressor use or the need for cardiopulmonary resuscitation within 6 hours of admission were not significantly higher compared with non-saddle pulmonary embolism. However, patients with saddle pulmonary embolism had a slightly higher risk of delayed decompensation with higher rates of mechanical ventilation and delayed thrombolytic use 6 hours after admission. A notable feature of patients with saddle pulmonary embolism is that they present more frequently with deep venous thrombosis on hospital admission. The authors recommend that optimal clinical management of patients with saddle pulmonary embolism should be based on the initial and delayed clinical and hemodynamic status, rather than the location and the extent of the anatomic clot burden. You can access these highlights and editor choice articles free of charge during the entire month of October. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you will find other free content such as our Path to Patient image quiz, art at Mayo Clinic, stamp vignettes on medical science, and interesting medical images. Please also access the social media buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. Our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. You can also check out our YouTube channel, where you can find videos of full author interviews and our 60 seconds video article summaries. Please listen to our Mayo Clinic Proceedings fireside chat recording, which is available through iTunes as well as our website homepage. And, as always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.